So pressure ulcers occur when tissue is compressed between a bony prominence and an external surface for a prolonged period of time. As you can see, the factors that lead to pressure ulcers are similar to the factors that we talked about earlier in terms of wound development. One that is a little bit different is the friction and shear forces. So you see in this picture, a woman, a patient, we're assuming, is sitting in bed, and what happens is the person will slide down towards the bottom of the bed, and this friction and shearing causes the epidermal layer to slide over the dermis, causing damage to the vascular bed. It happens when the head of the bed is elevated and the patient slides down, and it's common in the sacral area. Another factor is the moisture that builds up from urine, feces, or perspiration, and that macerates the skin and further complicates the situation. This slide shows the common sites for pressure ulcer development, and you can see it's where all the bony prominences are putting pressure against a hard surface and decreasing the circulation to that area. So pressure ulcers, for documentation purposes, are staged. Stage 1 pressure ulcer has intact skin with a non-blanchable redness. Now, if the discoloration remains for over 30 minutes, it is considered a stage 1. The area can be painful, it might be firm, warm, or cool compared to the adjacent tissue. And then with stage 2, there is partial thickness loss of dermis, and it can present as a shallow open ulcer, or it might appear as a ruptured serum-filled blister. And if you have a blister that's intact, it's going to develop into a stage 2 because the skin will be opened up. And then there's stage 3 pressure ulcers, which has full thickness tissue loss, subcutaneous fat may be visible, and bone, tendon, or muscle is not visible. In stage 3, it's not unusual to have undermining of adjacent tissue and tunneling. The area surrounding it, the peri-wound area, will feel boggy or crackly in these situations. And then the most serious is stage 4, where there is full thickness tissue loss with exposed bone, tendon, or muscle. Undermining and sinus tracts are common with the stage 4. The depth varies by location. Stage 4 are very shallow on the nose, ears, and occipital areas because there's no subcutaneous tissue, whereas it's much thicker in areas like the sacral and hip areas. When you're documenting on pressure ulcer stages, if a stage 3 or 4 heals, you don't say that they become a stage 2 or 1. What you say is that the pressure ulcer is a healed stage 3 or a healed stage 4. Two other ways of staging a pressure ulcer would be to be calling it a suspected deep tissue injury, or SDTI. This appears as a purple or maroon area of discolored intact skin or blood-filled blister due to damage of underlying soft tissue from pressure or shear. You see this often when people, generally older people, come in to the hospital after having fallen at home and not been found for several hours to several days. So when they come in, the skin is intact. This looks like very bad bruising, but eventually, as the wound heals, it pushes out and becomes an open stage 3 or stage 4. And then there's the unstageable pressure ulcers, and this is a full thickness tissue loss, but the base of the ulcer is covered by slough or eschar, so it cannot be accurately documented. It's generally stage 3 or 4, or it might be stage 2. As you see in the corner here, this is a full thickness heel pressure ulcer, and it's necrotic, and in this case, you do not want to debride the necrotic covering because it is actually protective. So you're also going to be wanting to note the area around the wound, the peri area, to make sure that it's not macerated from moisture dressings, and if there's undermining, that you're checking for that boggy feeling of that occurs with the undermining, or if there's crepitus, which is gas trapped under the skin, palpating the area might feel crackly. And you want to be looking for signs of infection such as erythema or swelling. And you want to see if the area around the edges is rolled under. And this is called epibole. So the first step in the nursing process for wounds and pressure ulcers is always assessment. So you want to use a scale such as the Braden scale, which can identify patients at risk for wounds and pressure ulcers and develop preventive interventions in the case that it's a high risk or an actual situation. So this is the Braden scale, and it measures a person's sensory perception, moisture, activity, mobility, nutritional status, and the friction and shear. And this is what you're going to be using to assess your patients. In the hospital, we use it every shift, and it's always needs to be rechecked because conditions of patients and your residents in the nursing home change pretty quickly. So after you've done the pressure ulcer risk assessment, you're also going to want to actually document the skin assessment, the appearance of the ulcers or any wounds that are present. You're going to be measuring the size, length, width, depth, documenting the color, the stage, the odor, the approximation of all wounds. And the way you describe the drainage is using these different terms here. Serous drainage is clear to light yellow. It is the straw-colored fluid that separates out of blood when a clot forms. And this is normal, healthy fluid. Then there's the sanguinous, which is bright red. It indicates fresh bleeding, and dark brownish red appears as the bleeding is older. And then you have purulent drainage, which is thick and malodorous, contains white blood cells, bacteria, and cellular debris, and that can indicate infection. So as I said, you're going to be measuring the amount, the color, and the odor of drainage. There's also the RYB wound classification. A red wound you want to protect, but it indicates normal healing with that granulation tissue that we were talking about. With yellow, you want to be cleansing the area. It indicates exudate and a buildup of those microorganisms in the open wound. And then with black, you may need to do some debridement. It's the least healthy development in a wound, can indicate necrosis and tissue death. So depending on the wound color, you would be tailoring your wound care. And these are various suggestions for the different type of wound color that you might come across. So here's some more examples of wounds that you might see. These three do not appear to be healing well on top. This is some eschar building up. The next one has some necrosis. Here you see an amputation that appears to have some necrotic buildup, some bleeding. Down here on the bottom left hand, you see a wound that has what's called retention sutures, and these are put on wounds that are highly likely to dehisce or have trouble healing because of the extra stress from either being overweight or have indications of poor wound healing. This middle one looks like maybe a stage 2 pressure ulcer. It looks pretty clean. If that's treated well, pressure's kept off it, the wound's kept protected, that might heal up nicely. And then here you have a couple of examples. This is probably an arterial, it might be a venous ulcer, but this is before and after, and see how it's healed up nicely. It takes a while, but it can happen. So once you've assessed your wounds, you're going to figure out what the priority problems are, make your nurse diagnoses, and then your expected outcomes. So remember, the expected outcomes always have to do with what you want to see happen with the patient. So if the patient is at risk for impaired skin integrity related to immobility or any other problem, then the expected outcome is that the patient will maintain skin integrity through hospitalization. Now, as you can see, it can be a risk, a potential problem, or an actual problem. So if there wasn't actually a wound, then you wouldn't say risk for it, you'd say infection related to open wound. And in this case, if they do have an infection, you want to see the area to be healing well and no new areas of breakdown. It might be a knowledge deficit related to wound care. In that case, you want to see the patient to demonstrate the wound care changing before discharge. And then you develop your plan. And these are the nursing interventions. And this is what you will be doing, or you'll be teaching your patient to do, or you'll be instructing the caregivers. You always want to assess the skin over bony prominences every shift. Turn and position the patient every 2 hours at least, and have a turning schedule in the room. That improves communication. Use pillows or foam wedges between opposing bony prominences. Use appropriate support surfaces, special mattresses. You have air mattresses and different mattresses that can help wick away moisture from wounds, or for people who have a lot of drainage. Minimize skin injury from friction and shearing forces. Try not to massage bony prominences. This decreases circulation even further to those areas. Protect skin from moisture. Use a barrier cream or some kind of absorbent pad under the patient. Make sure you're doing the dressing changes and wound debridement as ordered. And nutritional assessment is always very important. There's various types of wound debridement that you might come across. The sharp debridement, that's done with a scalpel or other sharp instrument, and that can be done right at the bedside. I see wound care nurses doing that pretty regularly just to keep the area clean and keep that eschar from building up. And then you have mechanical debridement with wet to dry dressings or hydrotherapy and whirlpool treatments. You might come across enzymatic debridement, and they use some type of a proteolytic agent to help break down the necrotic tissue and clean the area with normal saline and apply different types of creams. You might have autolysis, which uses occlusive dressings, and those are changed every 3 days and has material in it to help debride the wounds. And occasionally you'll still come across maggot debridement, which is using the larvae of the green bottle fly to secrete enzymes, and this helps dissolve dead and infected tissue. There are several choices of wound dressing products that you'll be coming across in your practice. One example is the transparent film or the Tegaderm, and these are used on superficial or stage 1 wounds. This is an example here, and this is another one. And these allow for oxygen exchange, and they protect against infection. You might also see the hydrocolloid dressings. Duoderm is an example. These are left in place for 3 to 7 days. They're more occlusive, but they do have some absorption of drainage and can be quite effective. You have hydrogels, which are ointments that you add onto the wound bed, and it helps keep a moist environment. This requires a secondary dressing to cover, keep in place. You have alginates. Alginates are from brown seaweed and kelp. They help absorb exudate and help prevent infection. You have foams that promote a moist environment as well and help protect the friable peri-wound area. Antimicrobials are silver or iodine based, and these help prevent and reduce infection. Collagens are made from cow or pig source. And you also have gauze, the 2x2s and 4x4s you see frequently placed over. They can have medicine applied to them to help with the wound healing. If you do see a gauze dressing, it needs to be changed daily because gauze is a good medium for bacterial growth. And the final stage in the nursing process is evaluation. You need to be reassessing your wounds and your dressings at regular intervals and determining the effectiveness of the treatment. Here's a question that you can read through and we'll go over when we meet in person. And it's a select all that apply. So you know at least 2, if not more, of these answers are correct. So you can give yourself a chance to look through that and see if you know what the correct answer will be. And finally, another intervention for wound care is heat and cold application. And it's important to know what the effects of these are. With heat application, peripheral blood vessels are dilated. There's increased tissue metabolism, increased blood flow, reduced muscle tension, and some pain relief. And with cold application, the peripheral blood flow is constricted. It can help reduce muscle spasms. It also reduces pain and inflammation and helps control and decrease bleeding. And what you want to know for both of these is overall safety measures. You want to avoid direct contact with heating or cooling devices, so you're always going to cover the area with a towel or sheet so that you're not causing more damage to the skin by the treatment itself. You want to apply heat or cold intermittently for no longer than 15 to 20 minutes, and then usually it's ordered for every 2 or 4 hours, so you're just going to be following that process and not leaving it on too long. And then you want to check skin frequently for redness, blistering, cyanosis, or blanching, which can occur from these treatments. So these applications can be moist or dry. With moist heat, it's often applied with a washcloth, towel, gauze compresses, soaks or baths, such as sitz baths for the peri area. Or dry heat, so using electric heating pads or aquathermia pads. There's a high risk for burns using dry heat. Cold therapy is often used for treating fevers, sports injuries, and preventing swelling after surgery. And the same thing, you want to make sure it could be moist or dry and follow those safety measures. So this is the end of the narrated lecture on skin and wound care. There's a lot of important information that has been discussed during this lecture. If you have any questions or any ideas or comments you would like to share, please use the drop box on the main page of the Nursing Skills Fall 2017 eClass site. Thank you.